During COVID, we responded as a system out of necessity very quickly. So we had that single front door space, that front part of the patient journey. We also saw the hospital in the home services use virtual care for people that were admitted patients. What I would love to see is a patient journey that enables someone to not have to set foot in a building that's a health facility if it's not required.
I'm Dr Louise Messara, and this is the Future Health Podcast. Today, we're exploring the dynamic landscape of virtual healthcare in New South Wales. We'll spotlight the changemakers driving recent innovations and explore some new services that you might not yet be aware of. Dr Karol Petrovska is the Director for Virtual Care at the New South Wales Ministry of Health. Karol has a clinical background in occupational therapy and has a doctorate in public health. Dr Jerry Yu is the General Manager of Virtual Care and Hospital in the Home Services at Northern Sydney Local Health District. Welcome, Karol. Welcome, Jerry.
So, Karol, let's start by framing the conversation for the audience. Could you define virtual care for us? I'm guessing it's more than a telehealth consultation.
That's correct. So in our virtual care strategy for New South Wales, we define virtual care as the use of information and communication technologies for patient to clinician or clinician to clinician clinical care. That's our definition, and the important part of the definition is that it is done in a remote fashion. So people don't have to be in the same room at the same time. You can have a clinician providing care from one part of New South Wales to another, and you can have clinicians talking to each other about a patient's care at a distance as well.
So I suppose that's really going to answer a little bit of what my next question was about, which is the particular sort of wicked health problems. This is a sort of a suite of solutions to tackle. You talked a little bit about distance. Obviously, that's a critical issue in Australia. And also the idea of the malleability of workforce being able to support a community where they're not necessarily in the same place. Are there other wicked issues that you feel really are in the purview of virtual health?
When we think about volume, virtual care is also incredibly useful. What virtual care enables us to do is to scale existing ways of working. So we have at the moment significant challenges with accessing primary care and GPs in New South Wales and indeed the rest of the country. And it's not unique to Australia either. That's a challenge internationally. So what we have are services like the single front door that use virtual GPs to provide care to patients that would otherwise be coming to an emergency department. They're low acuity patients that could be seen outside of a hospital. So virtual care enables us to provide a service to those low acuity patients, thereby leaving the emergency departments free for higher acuity patients.
So that's the efficiency element, I suppose. So we've sort of equity, access and efficiency is that sort of triangle that I think we're always looking at each new innovation to make sure we're tackling. How does a patient engage with single front door?
Okay, so we use Health Direct, which is a Commonwealth-run organisation that all the jurisdictions contribute to in terms of the business model. And we have a phone number that people call, and they are provided a service by a nurse who triages them according to their level of need and acuity. And if they need primary care access, then they're sent through to a virtual GP who is able to provide them primary care. It may be something like a script for a UTI, for example. And we're finding that if we look at the categories of emergency patients, categories 1 to 5, 1 being the most serious, 5 being the least serious, the category 4s and 5s level patients can be seen by the virtual GP who provides that primary care service that people would otherwise be coming to an emergency department for.
So this is in addition to, where we've got co-located primary care sort of attached to some of the emergency departments now.
That's correct.
Okay.
And we're also using Health Direct to make appointments for people to go to urgent care services, the bricks and mortar services that New South Wales is funding. So Health Direct can make an appointment for a patient to then walk into a bricks and mortar service.
Okay.
And if they need to be seen face to face, then that service is there available for them.
So tell us a little bit about some of the leading innovators in the space in New South Wales. Who are some of your change makers?
So I'm sitting next to one of them, Jerry Yu.
Jerry.
So Northern Sydney Local Health District have really developed a model that works not just with virtual care, but working with virtual care in a hybrid model. We're very careful to position virtual care as something that can absolutely be used for appropriate patients, but sometimes those patients may need face-to-face care as well. So what Northern Sydney Local Health District has done is develop a hybrid way of working. They have their hospital in the home service. They have a front-facing service to the community. They also work with ambulance and paramedics, and that's all incorporated into a virtual hospital style of model that can flex in and out of face-to-face care depending on the patient need. But quite often these people can be seen using a video conferencing assessment or using remote patient monitoring, where patients wear devices and they're monitored remotely centrally at the hospital.
Are there perhaps some new and sort of novel pathways or models of care that step even beyond that contact point with the practitioner that maybe are with us now or are about to come online?
With us now is remote patient monitoring. So that was certainly used a lot during COVID, and what that involves is patients wearing devices, either a pulse oximeter on the finger or somehow taking observations in the home and then plugging them in or Bluetoothing them in to their iPad. And that information is shot through to the central place, either the hospital or the service, and several patients' observations can be monitored on a dashboard. And if there is an escalation of a patient's needs, if they needed to be attended to, then that is flagged on that dashboard that is monitored by a clinician. So that is a really great example of how virtual care can enable us to manage and monitor a large volume of patients simply by looking at a dashboard and seeing what their observations are telling us. So during COVID, patients' oxygen saturation levels were monitored remotely at quite large volumes of patients, so hundreds of patients. And you can understand, if it weren't for virtual care, then those people would need to be seen by a clinician driving around the community, seeing hundreds of patients over weeks and weeks at a time. So the efficiencies are quite significant when you look at that.
So a real opportunity for wearables becoming more than a sort of a fitness tool.
Absolutely, and I think we are very close to, and some services are already embedding this in their business as usual. The wearable devices that we have on our wrists, many of us have on our wrists, will eventually be linked to these services so that patients won't have to wear an additional device or add an additional device. They've already got their wearable. So that future's it's
pretty
already
much here.
here.
We talk about hybrid and we can think about that in terms of the service delivery, but also you talk about a dashboard that's reviewing clinical parameters. I suppose we could take a hybrid view of that as well around the possible relationship in the future for AI to be doing that first screen rather than having to have a clinician reading the results on a dashboard. Do you see that that's a sort of a relationship that's only going to be enhanced?
I do.
Or enhancing?
I do. I think for us in the AI space, what we need, I think, is, some regulation and some further understanding and evidence to ensure its safety. We were in this position not that long ago with virtual care where the evidence was, we didn't have the luxury of tens of years of evidence by which we can make strategic decisions on. We're getting that now. We're seeing virtual care is as safe as, if not safer, and a better experience for patients and clinicians in many, many ways. I think we need that for AI, but it's close. It's very close.
Are there world exemplars that we should be looking to or we do look to? Or are we the exemplar here in New South Wales?
I think from a rural perspective, we're an exemplar. The Virtual Rural Generalist Service in Western New South Wales uses something that we call a Chasing the Sun model, where we have clinicians that live overseas that provide virtual medical cover for facilities in Western New South Wales Local Health District during those overnight hours when they can't get a doctor to be on the premises.
So these are Aussie-trained doctors?
Aussie-trained doctors. All of their clinical governance and credentialing is done as per normal district employment approaches. And one of the requirements for that model, which I think is really clever from a team building perspective, is that those clinicians are required to spend 3 months of the year in the local health district, so they understand the local referral pathways, they understand what the services look like. And I think that is a really positive thing for patient experience. We know there are virtual medical cover models running in a lot of places, but that local understanding is really key to how the virtual rural generalist service
And
works.
a really nice opportunity for work-life balance for workforce as well. If you,
Absolutely.
you want to take some time, do some adventuring overseas, but still retain a connection. And,
absolutely. And I
position.
think the evaluation of the virtual rural generalist service is saying exactly that. We've, traditionally, as GP numbers and doctor numbers have dwindled in rural areas, we see doctors being sort of working long hours and burning out. And the feedback from the evaluation from the doctors has been, I have a life now. I can stay in this town that I love and that my family has grown up in, but I have a life. And that has been a really great part of the VRGS model.
So, Jerry, when you're thinking about the services to innovate in next, or what the next projects might be, is it a question of clinician innovation? Is it a question of consumer demand? How do you think through what comes next?
I think it's a combined effort. So it is consumer preference, where care can be delivered in an innovative way. It should be a clinician-driven models of care, and also looking at where are the pain points, so that how can we address these pain points? Can we make it easier for our consumers, make it easier for our clinicians, and maximize the clinicians' time and effort in looking after patients instead of working on something else?
Where are the opportunities for consumers to highlight a pain point or talk to a human about where they think there's an opportunity for a service?
So usually when we design a mode of care or develop a service, we usually go through our consumer advisory group. We have an active consumer advisor sitting on our steering committee, and also we measure our service based on the consumer or the patient reported experience and outcome. So this is how we design, monitor, and evaluate our new models of care, making sure that we are actually addressing the consumer's needs in the community.
I suppose that's also a great tool then for getting feedback around, you say an improved patient experience. I've seen some recent studies coming out saying better for workforce, better for patient experience. So is this one of the mechanisms for receiving that feedback?
Correct. And we're also getting feedback from our workforce as well, so measuring their job satisfaction. And then we found usually people are getting a higher job satisfaction working in an innovative model and knowing that we can actually contribute to something meaningful in the community in terms of promoting health and promoting the efficiency and effectiveness of the care that we deliver.
With your clinical background, I think we hear about so much opportunity with technology, but there are some aspects of what we all do that maybe some might think should be ring-fenced from the intervention of technology. How do you grapple with that idea of what really needs to be delivered human to human, face to face, or do you think we're past that now? Is there anything that you don't think that hybrid or virtual environment is really the right modality for?
At the moment, some acute care should be happening in a brick and mortar hospital that is complex. There's always an element of virtual or digital or technology support or factor in all the care that we deliver. So I think as a first step, as the community or as a whole health system, if we can look at what are our consumers' preference, what are the things that we can deliver effectively in a virtual way, and also provide a hybrid model in terms of the patients can receive care in a virtual way by using a smart device. The patient can receive care in an assisted virtual way that we assist them to provide care or monitor their conditions, help them to maximize their self-management in terms of their, for example, acute or chronic conditions. And also remain a face-to-face or traditional option for the patients to access care. I think this is a key moving forward to actually make sure that we capture the whole population within the community and by providing those hybrid model.
Yeah, I think being responsive to the community is incredibly important because at the end of the day, we can have all the technology at our fingertips, but patient acceptance is really going to determine whether this solves a real problem or not. I wonder if you think there's an age difference in patient acceptance of some of these models of care. And I think, we have this idea that older people are less comfortable with technology, but, plenty of grandparents are out there Zooming with their grandkids and actually probably much more au fait with a lot of the technology than we give them credit for. But we also have a younger population who've grown up knowing nothing else and would probably prefer to be sitting at a desk somewhere and really only engaging sometimes with a hybrid or a virtual model. Do you think as we move through these sort of age groups, is that going to be one of the defining features of how virtual health really explodes?
I think the whole, everyone is actually moving into a more digital space. It's just going to take time. And then we need to actually focus on the public acceptance, digital literacy, the technology, the infrastructure. And also, I think it's not an age-related issue. So we get a patient who's over 100 years old, and then we still monitor and review them and providing some physical exercise for this patient to follow. And then the way that we get around is that we get a lot of family support for patients who are not so comfortable with their devices. And then we get the family and neighbor support, or we sometimes go out and then support the patient in terms of setting up the devices. So there's always strategies that we can implement to address some gaps there.
I mean, that's raised another point around, I suppose, equity. Yeah. Not everybody has a smart device. Not everybody has a wearable. What does New South Wales do when we're working in communities, or maybe, 5G isn't, all of these sorts of issues? How do you try and tackle those, big sort of systemic problems?
I think depending on what is actually available and what clinical needs are. So, for example, during COVID, we started with just calling the patient, ask them, what is your oxygen saturation? So that actually helps us, and ask them a series of questions. That helps us to monitor those patients and provide education and training in terms of how to manage our respiratory symptoms at home. It is really depending on what is the healthcare needs, what technology is available, but we need to make sure that we get the clinicians to lead the care and then have the technology to follow. And in terms of the availability of the technology, if there is a missing part, then I think we should be providing the technology to the patient. Or if a virtual way is not suitable in some circumstances in terms of, for example, connection or whatever the issue is, if we temporarily can't address this issue, then we can provide a hybrid model that is face-to-face.
Yeah, I mean, you can still see the significant cost effectiveness of providing a device versus a hospital bed for the day. Yeah. So I appreciate that. Karol, there's a bit of evidence that there's been a sort of a bit of a drop-off of the use of virtual care following COVID. Was that what you expected? Was that surprising? Why do you think that's happening?
I'm not surprised because we're not locked up in our houses anymore. And what we've seen is a drop, but then it's stabilised and it's higher than pre-COVID. So that tells me that there's been a shift from the community towards acceptance. I still think this is a cultural change in how healthcare is delivered and received, and we're not going to achieve that in a short period of time. This is a change management piece for the community. We need to work with the community. We need to work with clinicians. We need to think about normalising virtual care and not treating it like it was a COVID thing and now it's back to normal. I think that is a piece that not just speaks to change support for the community, but the clinicians as well. How do we embed virtual care into curricula? How do we embed virtual care in education once clinicians are out and they are required to do mandatory education as a part of their registration? They're the kind of conversations I think we need to be having over the coming years. And our virtual care strategy, I often say it's a 5-year strategy, but this is a generational change. We're not going to achieve the normalisation of virtual care in 5 years. So it's a comms and engagement piece for us.
I mean, I want to tackle education and training, but when you think about how you're going to promote this service, I work in health, but there would be a lot that is going on around the corner at Royal North Shore or Northern Sydney Local Health District that I don't know about as a consumer or user. So what tools are you planning on utilising to really promote the services that are available for people to reach in and make use of in the community?
Yes, so I think we've got the traditional ones, which is website content, a lot of videos showing the patient experience, and we've tried to focus on lots of different examples. So pediatric examples, Aboriginal patients using remote monitoring. We've got elderly patients using the telestroke service. So we've tried to look at different ways of telling the story.
And is that on social media that they all play?
That is also on social media.
Right.
It's on social media and it's on our website.
Okay.
So they're all available now.
Okay.
But I think we need to move beyond that original comms piece, and this is about ongoing engagement. So we do things like community forums. We call them kitchen table discussions. We have several consumers that we work with as a part of our virtual care governance groups that we have. And we've asked them in the past, and I think it's something we need to continue to do, is to lead community engagement discussions, because it's not just putting some comms out there and putting some things on social media. It's an ongoing discussion. Also very careful to ensure we include different parts of the community. So beyond older people, we're working with National Council of Social Services. We're working with Aboriginal in the NHMRC. We're working with people who sit in that vulnerable group space, people with a disability. So we need to understand what virtual care means for those groups. Sometimes it's around affordability. People don't have a lot of data to burn up using their data for a video call, for example. And so just going back to what you were asking Jerry about before, we certainly recognise the challenges around connectivity in some parts of rural New South Wales, but also depending on where you are in Sydney as well. If you're unfortunately in a basin somewhere, connectivity is challenging in a lot of parts of New South Wales. So that together with access to devices, I think, in lieu of providing everyone with a device, which is sometimes the answer, we also think there's opportunity for community hubs that are set up to take virtual care appointments and provide that connectivity. We see examples of that in Murrumbidgee Local Health District. Their multi-purpose services have a virtual care room. So people can travel to their local MPS to see a specialist that might be based in metropolitan New South Wales. So that connectivity issue can be resolved that way. We have Aboriginal Land Council in Port Macquarie that has a virtual care room where community can go. If it's a safe place where people feel like they can turn up, get their healthcare needs sorted through virtual modalities, that's also a way of solving that connectivity challenge.
We live in a very multicultural community. How do you find sort of communication through the virtual environment? How do you manage that aspect of care? Because I imagine that's an extra layer of challenge.
It is an extra layer. So we also use interpreters through virtual means as well.
Okay.
I think for us...
Again, that will be a technology space, won't it? You'll immediately get some sort of translation as part of the technology in the next few years.
That's absolutely. I can
it's probably
see
there
that.
already.
Well, probably.
Yeah, somewhere.
So probably somewhere.
Yeah.
I think our interpreters, I think what we would love to see is really streamlining those workflows so it's a very easy pathway for interpreters to join the clinical conversation. I think at the moment there are several steps we need to go through and then it's set up and it works. I think an area for us to concentrate on in the near future is supporting culturally and linguistically diverse populations to access virtual care. I think the feedback from that particular community group is they're a little bit unsure about it. And so that's, part of that community engagement piece. We need to invest in understanding what works for communities and what doesn't work. So that's our work. That's what we need to concentrate on.
So, Jerry, this is a burgeoning space, which means we need workforce. Is it a sexy offering when you're out there recruiting? Are you getting queues around the block?
Definitely it is.
I mean, look at us.
Definitely it is, because I think this is something new, something innovative and also exciting. So we get a lot of clinicians who really want to make a difference and then help the community. So yes, it is a very sexy offer.
Are there specific attributes you're looking for in a clinician who's going to work in virtual care versus a sort of face-to-face dynamic? Are there special skills that really these people need to possess?
So I think I'll put adaptability as first, because these kind of innovative models are evolving all the time. So people like us, we are trying to evolve and lead new models of care, need to be at least adaptable to start with. And you add an element of technology in there, then an element of clinical skills and knowledge in there. So that would be a perfect person for us.
We talked a little bit about the idea of virtual offering a sort of a new flexibility. Often when we're talking about the future of work, we know we're competing with other sectors that can offer all sorts of work from home options, flexible hours, which up until now, health's been fairly restricted in its offering and its competitiveness on that basis. I suspect that for people looking for that flexibility and balance, you're really offering something that means they can travel, they can be working from anywhere. Are you seeing a different group of clinicians sort of putting their hands up because of that?
Yeah, I think it's already happening. We've got, as Karol mentioned before, we've got doctors working from overseas supporting our patients. And then I know that there are clinicians working from home or working from a different location to support a virtual service. It is actually on the table and it is already happening.
Do you think being adept at delivering care virtually really is going to have to become a part of every clinician's toolkit? Or do you think this is going to become eventually a specialty of its own?
I think innovative model or hospital substitute or a virtual hospital model of care is a specialty in its own. But virtual care is really everyone's business. So it will become a normal care model. So in the next 5 to 10 years, we might be talking about care in a digital age instead of we're talking about technology, digital, virtual.
So I suppose we need to be working with universities and education providers and colleges. Is this happening already? I went to medical school a long time ago. There was no such thing. Is this part of a curriculum already, or does advocacy need to be in play to make sure our education providers are providing the right education for the future or the care that we're now providing?
I think it's coming. It's happening already. So I noted that the Australian Remote and Rural Medicine College has got a virtual module on virtual clinical skills. So we started with us teaching ourselves how to conduct virtual appointments, check people, and then check on their COVID status. And then we learned the technology, and then now it's actually evolving into the clinical aspect, the clinical skills, utilizing virtual models of care. So it is coming, and it is also evolving.
And we've talked about sort of doctor appointments and nurse-led initiatives. I presume the opportunities across the whole gamut involving all allied health professionals as well. Do you see the way sort of the Medicare system works as a bit of a barrier to you being able to source appropriate funding for some of these really necessary models? I know rural regional Australia is desperate for allied health support. Do we need some revolution there to assist your project?
Yes. So I think for us, it is about those MBS items that enable virtual care. It's also about how virtual care is funded from an activity-based funding perspective.
Yeah.
We would love to see some more agility in those two spaces. What we're seeing is the state-run services moving forward at a great speed in terms of innovation and the use of virtual care. And the Commonwealth space is usually a couple of years behind. So, and look, we've had some great conversations with our Commonwealth colleagues. It's the wheels of bureaucracy turn slowly. And so we often have had discussions about agility, keeping up with the digital space and digital innovations. And I think they also recognise that there needs to be some further agility in those two spaces.
Karol, when you're thinking about strategy, and you talked about a 5-year stroke generational project, is the setting of strategy at a state level, or are the LHDs really running quite distinct programs and distinct strategies over the next decade?
Bit of both.
Okay.
What we have tried to do over the last 3 to 4 years since I've been in this role is understand that LHDs need their own strategy because it's unique to their population, but that it speaks to the state strategy. So that alignment is something we've been working really hard on. I think it's at a really good place. And I think what we've done is invest in the relationships early, because now we've got this kind of system between us and the LHDs where we connect really well, we connect regularly, we are very open to understanding what unique needs are and why things need to be a certain way locally. And I think that partnership is going to be really important in everyone sort of singing from the same song sheet.
What's next on your roadmap?
Ooh, quite a lot of things. I think what I would love to see is during COVID, we responded as a system out of necessity very quickly. So we had that single front door space, that front part of the patient journey. We also saw the hospital in the home services use virtual care for people that were admitted patients. What I would love to see is a patient journey that enables someone to not have to set foot in a building that's a health facility if it's not required. So we could get someone phoning in through Health Direct at that front door, and then that front door speaking to an urgent care service, and that person perhaps being referred to a hospital in the home service that provides virtual care. And that patient may never have to set foot in a facility because they're simply well enough to stay at home but require ongoing care through those virtual means. That would be a nirvana, I think, for us. I think several of those services are in existence, but they've sprung up on their own, and joining them together would be
Well, I was going to
ideal.
say, what are the barriers to this vision becoming a reality? Because as you say, they're all there as distinct entities at the moment, or services.
Yeah, the barriers are they're currently fragmented, and I think we, as the system lead, it's incumbent upon us to demonstrate the positive outcomes that can eventuate from that patient journey being a continual journey through virtual means, still receiving the care that they need. If their level of acuity increases and they need to come into a bricks and mortar facility, then that's a seamless experience. Our services should bounce in and out of virtual and face-to-face according to patient needs. So that agility, again, I come back to agility.
Interoperability,
Yes.
All
this
of that,
is it,
all
yeah.
that integration is really what's next on my radar.
Is there an advance, a technological advance that you're waiting for, that you know when you have your hands wrapped around that, it's really going to mean leaps and bounds for virtual healthcare?
I would probably go to digital integration as the key part that would make this a seamless experience for the patient and the clinician. So when I talk about integration, it can mean one of two things. Services are integrated so that if a patient, if their acuity increases, then it's a seamless experience going into a bricks and mortar facility. But the digital integration is the key part. So what we've got at the moment are clinicians working very, very hard using digital modalities and then having to go to the patient record and re-enter information. So in an ideal world, it would all be captured in the one occasion of service where they wouldn't have to re-enter data in multiple spaces.
Yeah,
so
technology making life easier, not
absolutely,
harder.
yeah.
And Jerry, for you, working within the sort of clinical community, what are you hearing? What's the buzz? What is it that the clinicians are just waiting to get their hands on?
Yeah, I think digital integration, as Karol mentioned, is our key next step, and it is about interoperable data that clinicians can get access to. So at the moment, the system is still segmented in terms of, for example, we are not able to read the ambulance medical records. So a patient gets discharged from, for example, one of the senior local health hospital, and we don't get to see all those medical records. If we can link them up as a first step, then it makes easier for clinicians to get information. So then we are actually turning our clinicians from data collectors, we collect a lot of data, to data users. So once we link them up, how can we use this data better? How can we predict a deterioration? And how can we better support the patient to manage their acute and chronic conditions. So that will actually help in the future once we have a one set interoperable data set.
Fingers crossed, guys, because I think a lot of the public would be amazed that we don't. And I don't think anybody really yet realises the power of us actually having that tool. And I imagine huge innovation will be the result. So, Karol, Jerry, thank you so much for spending some time with us this morning. It's an exciting space.
Thank you
Thank
very
you.
much.